Thank you, good afternoon. Let me take you away from malaria. It's very interesting talks. Yes, I do research in the field of rheumatic fever and rheumatic heart disease. And that's going to be my outline. I'll give you an update on study progress and some scholarly activities and engagement. So rheumatic fever is an autoimmune mediated systemic inflammatory illness that is triggered by group streptococcal infection of the throat. And recurrences of rheumatic fever then leads to damage of the heart valves, and patients then come to hospital with rheumatic heart disease, which is a severe form of heart disease. The incidence of rheumatic heart disease is high in children, about 5 to 15 years, as you see in the blue line. And its long-term complication, rheumatic heart disease, happens in early childhood. The last time I gave you this talk in Moshi, the worldwide prevalence, or the number of people affected by rheumatic heart disease was 34 million. And then the global burden of disease came in late 2017, published last year, it's now 39 million. Unfortunately, most of these people reside in developing countries like Uganda. Rheumatic fever is diagnosed according to the Jones criteria, which has been modified many times. It's currently based on the 2015 criteria, which classifies it as criteria for those in high endemic areas and those in low endemic area. Basically uses major and minor criteria, and then there's evidence of infection based on blood tests, determination of anti-neutralizing or titers and anti-DNAs. The case definition then depends on how many majors, minors you have, and then the addition of the evidence of infection. Importantly, you then can say someone has definite rheumatic fever, or they have possible rheumatic fever, means that they have certain features of the criteria, and then they have evidence of the infection, and then they also have recurrent acute rheumatic fever. But there's a big gap in that we see so many cases of rheumatic heart disease, as I've told you, but we see very few cases of rheumatic fever. And yet rheumatic fever offers this opportunity for intervention, and it's very cheap to treat. Just someone needs a 6 months to 1 year injection with benzoyl and penicillin, compared to the very expensive heart surgery that they need when they develop full-blown rheumatic heart disease. So when we developed this study, we thought that maybe issues to do with poor health seeking, because rheumatic fever also presents with fever, and there are many causes of fever in our community, maybe poor disease recognition, and maybe different disease presentation may account for the curve that we are observing. So we sought to determine for the first time in Africa the incidence of rheumatic fever, and to look at the pattern and presentation of acute rheumatic fever among children who present for evaluation of fever and arthralgia. We had a number of objectives. When I started the postdoc, I had the first two, to do a baseline description and to look at a prospective outcome over 1 year. Then along the way, I got an additional grant, and we were able to add objectives 3 to 5 that importantly was looking at determining the normal ranges of the anti-neutralizing or titers, because that's the evidence of infection that's used in the case definition. And then to look at candidate biomarkers for trying to see if we can get signals that could then lead to a standard diagnostic tool. For now, the Jones criteria is clinically based and has many weaknesses. The study site has been in Dera, which is mid-northern Uganda, because of the high prevalence of rheumatic heart disease in that area. And I just summarize for you the different methods that we've used. So objective 1 and 2 are being addressed in a prospective cohort study, and this was determined at the start. We needed sample size of 1,300 children aged 3 to 18, and look at incidence. We have a descriptive baseline and follow-up outcomes. And then objective 3 is a cross-sectional that we did in healthy children and adults to determine the normal levels of the isotiters and anti-DNAs. And then objectives 4 and 5 were addressed in a case control study that's looking at genomics to try and understand the immunological profile of children with rheumatic fever. This case control study is unique in that we have 100 cases of definite rheumatic fever, and then we have 25 each of children who have rheumatic heart disease without rheumatic fever recurrence, children who are healthy, children who are referred for evaluation for possible rheumatic fever but found to have other causes of inflammation, and those who have non-rheumatic fever related inflammation. So the 100 controls you see there is divided into 4 different characteristics. For the main study, for the first study, the inclusion criteria was ages 3 to 18 who presented with fever and joint pain at any of the health facilities, and also if they had any of joint involvement. Those who were familiar with the Jones criteria in the past, you needed multiple joint involvement, but in the new Jones criteria, you need only one involvement. And then we're doing echocardiography to see if there's involvement of the heart, which is an important feature. We did extensive education of the health workers and schools and school teachers to try and improve surveillance for rheumatic fever, so that then they'll go ahead and refer the cases into our enrollment center at Lira Regional Referral Hospital. And so the variables that we looked at were based on history of fever and joint pain, history of rheumatic fever, children, and then we did focus examination and did blood tests, including important ones, assortators, anti-DNAs, and importantly at the bottom, we did the assortators in the normal population to try and average, because it's unclear whether when you're looking for evidence of infection, you should use internationally designed guideline levels, or you should determine your own and kind of adjust it to the background because of the very frequent infections with group streptococcus in a highly endemic area. So we had a little challenge in that when I did the analysis and we did the laboratory work for anti-DNAs, which is an essential component of the case definition, the lab in Uganda, which I was using, had issues and the results didn't come out well. So I had to ship the remainder of my samples to one of my mentors' lab in Australia. I just got the results back 2 weeks ago. So I'm giving you very preliminary results, but at least now we have all the results. Yes, so we enrolled from July 2017 to December 2018, and we had 1,218 referrals, 465 met criteria, mean age was 10.2, 52% for male, and 134 met diagnosis of rheumatic fever based on the Jones criteria. And this is just when we try to characterize that we have definite rheumatic fever, but we also had big number, 31%, that are possible rheumatic fever, and that has been our interest. That how about those who do not fit into the Jones criteria? If we study them better, does it, will it help us in better case detection? And that's the group that we'll continue to follow. Then we also have those who are non-alternate diagnosis. We had cases of sickle cell, we had cases of malaria who presented with features of rheumatic fever. Some might overlap. We're able to exclude others eventually, but there was overlap. Then there's that troubling group in yellow that came with fever, and joint pain, and they didn't fit the criteria of rheumatic fever and also didn't have a clear diagnosis. And we continue to handle them with the clinicians. So this is the result of the normal levels. So we got 428 children and adults, as you can see, the different categories. Different categories, so this is the ages, so 1 to 4, then 5 like that. And then, so this is the median of the anti-streptolizing all titers, that's the ages centile. And then you can see the ages centile for anti-streptolizing all titers coming at about 375 compared to the international guideline, which is 200. So in Uganda, we found that ours was much higher. And of course, the implication for that is that when you use it, then some people will not fit the case definition of rheumatic fever. which gives us more work to evaluate more. This is for anti-DNAs. Anti-DNAs is more specific than anti-circulating all titers. Again, its ATS center was at 568, which is much higher than the international level of 375. So again, that took us back, and we're continuing to evaluate these groups. So when we use the Ugandan cutoffs then to reclassify the results that we got, the number of cases definite rheumatic fever fell from 134 to 92, and the possibles remained along the same. And then we have this new group that we added. Those who had enough measure and minor criteria that we are following. Those are the people who have one or two features of the criteria or have evidence of infection that we're then continuing to evaluate and analyze with the plan to come with a clinical decision rule, as we'll see. So, very early conclusions. Very high cases of acute rheumatic fever in the community, higher than previously thought. Although we didn't have local data, but data from elsewhere showed us that there were fewer cases. I think we're just missing them as one. We're going to complete the analysis and eventually determine the incidence based on our population at risk, which is children who are 5 to 15, about 200,000 in number, based on the 2014 census numbers. And the many cases with possible acute rheumatic fever suggest that the Jones criteria may be too specific for our diagnosis of acute rheumatic fever. And the ATS center for upper limit of normal for the anti-circulating all titers and the anti-DNS, were higher than those based on the international cutoffs, and may need background adjustment. So my next steps are, now that I have all the results, are to complete my statistical analysis, which I had to hold because of the delay with the lab for objectives 1 and 2, and to resume my manuscript, which I started. And then I will complete manuscript for study 3, the normal level study. We have got the material for that. And then we're working on the genomics analysis for objectives 4 and 5. And we're working to develop a clinical decision rule so that where there's no Jones criteria, a health worker based somewhere in Africa should be able to diagnose rheumatic fever. I've been able to do 2 more publications in the last period, and I have 2 others under review. Submitted 3 grants, were successful in the first year. We had 2 grants in the first year, and then in the last year we've submitted 3 which are under review. We've continued to supervise 2 Master of Medicine students who have completed, and I have 2 PhD students who are continuing. And those of you read in the magazine, I was awarded, I was honored with a fellow of the American College of Cardiology back in March. I've been involved in community and public engagement work. There are issues with the community, so I had to go and appear at the radio station. Although by design of our study, I've always engaged the community, but I had to appear at the radio station because of the study nurses. And I had to appear with an LC5 counselor who, fortunately understood the concept very well, and she made the communication very well. And then many times we met children and their parents in the schools that are involved in the study. So just to thank you, and to thank my mentors, Professor James Tumino, if he's here, and my mentors who are not here, and Thrive and Okello. Thank you.
Thank you.